Welcome. I'm so excited. I have today Dr. Rocio Salas-Whalen. I hope I pronounced that correct. Dr. Salas is a New York City-based triple board certified physician with broad experience across all facets of endocrinology with an emphasis on women's health and obesity. And you've probably seen her online. She just has so much valuable information. We're just going to go straight into GLP-1s. So Dr. Salas, a lot of people think of GLP-1 medications like Ozempic and Wegovy. They're kind of like quick fixes for weight loss. Can you explain actually how they work and how someone can think of it as part of a broader weight management plan?
Yeah, definitely. I think first to say that they're not a quick fix and that patients that take these medications is not a easy, quick way out. It actually requires a lot of work if we want to get great results. The way that these medications work, I like to very easy simplify it into thinking of the two reasons we eat as humans. We eat for fuel, survival, right? For energy. And then we eat also for a reward or an anticipation of a reward. So these medications really target both things. So they increase our satiety hormones, our fullness hormones, and they decrease our hunger hormones in between meals. So you eat more smaller portions, feeling content. You still eat, but definitely is going to be reduced. And then for the reward area and the hedonistic eating and drinking center in our brain and the amygdala, we have receptors for this medication. And what they do is they remove any reward from food or any anticipation of a reward from food. So emotional eating, boredom eating, also for alcohol consumption. So whatever is giving you some sort of a reward in regards to food and beverage, this medication helps to remove it. So the behavior changes and you're also decreasing your caloric intake.
So all that sounds like beneficial. And why wouldn't anyone turn towards that in terms of seeking weight loss? So what are some of the, I guess, potential side effects or downsides that might happen for individuals?
So what I've seen through the years of using them is the effectiveness and the safety of them will depend on the expertise of who's giving you this medication. So if you go with somebody who does this every day, every single day, multiple times a day, that has many patients on them, the likelihood of side effects are very low, right? I would say the garden variety of side effects, no matter how good you are as a doctor, could be nausea, constipation, dehydration, because again, it takes away your hunger. And normally we drink our liquids when we're eating, so you'll be drinking less. Muscle loss can happen with any type of weight loss, right? Diet, medication.
Mm-hmm.
But again, here comes the expertise of who's going to guide you through this journey. For my patients, what I like to concentrate is a lot of muscle, preserving muscle or muscle building. So it's not like you either use the drug and have muscle loss. There's a midpoint, right?
So what are certain health situations or conditions where it's a contraindication for someone taking a GLP-1?
There's only one contraindication really, which is a personal or family history of medullary thyroid carcinoma, which is a very rare and aggressive type of thyroid cancer. So that's the absolute contraindication that we have currently for this medication. But any other type of thyroid cancer, papillary, follicular, hurdle cell, those are not contraindication, or having thyroid nodules is not a contraindication for using this medication. Now, somebody who's had pancreatitis, then that's a little bit more per case basis. I wouldn't say that it's an absolute contraindication, but just even more the expertise of who's giving you this medication will really be important.
That makes sense. And another reason why seeing a doctor versus going to a med spa would be
or getting
better.
in with filling a form. Yes.
So I've had a few trainers come in with this question because as this becomes more popular, we're getting clients that are on GLP-1s. And so this I had a few trainers ask. So they've got clients that are losing weight on GLP-1s, but they're struggling to gain and maintain muscle because it is the clients, their appetite is lower, their energy is lower. So for someone in the fitness industry, what is your advice on how a trainer can support their client during this time?
I say thank you to the trainers that are thinking that way and not as a potential conflict of interest, right? In regards to what you guys do. I think more than ever now, I've never referred so many patients to a personal trainer as I do now that I started on GLP-1s on my patients, right? So the most important thing when a patient is on weight loss medication on a GLP-1 is to preserve muscle, and that's going to be with the aid of protein in the diet, increasing the protein requirements. Now, for some patients that have lost muscle or that are starting at a low muscle mass, then it's not just preserving, it's actually building muscle. And that's where it's like the holy grail where you're losing body fat and gaining muscle mass, right? The medications take care of the fat loss. Now, the patient, the doctor, and the trainer will take care of the muscle building. So I recommend to my patients heavier lifting and definitely higher protein intake in the diet. And when you go to an experienced doctor or an obesity doctor, they're going to do body compositions. And in the body composition, we can really pinpoint what's your muscle mass and what segment in your body, is it your legs, is it your core, is it your upper body or your arms that need to build muscle, and then really have a conversation. It's a team effort, right? Have a conversation with the trainer and look, this patient needs to build muscle in the lower extremities. This patient needs to build muscle in the core. We're increasing the protein. Now he needs to do heavy lifting. So more guided towards heavier lifting for muscle building.
Well, all us trainers, we're all pro heavy lifting. That's actually helpful to suggest that the trainer should be in conversation with the doctor, especially if you're doing body comp, to know what part of the body needs more muscle mass or needs more building.
Now, before another question that one of the trainers had is, what if they cannot gain muscle or they're struggling? So,
yep.
They may be on a higher dose than what they need to be in regards to the medication, right? If they're in a dose that cannot consume certain amount of protein and we're sacrificing muscle along the way, then we need to come down on the dose for the greater good of muscle, I tell my patients, right? So it's not just like the fixation on losing, is what are you losing?
Yeah.
If you cannot consume the amount of protein that is recommended with the dose that you currently are taking, then that's too high of a dose.
That's good to know. Actually, I was going to ask, that was a very good point you made about how when people lose weight, they also lose muscle mass, regardless of GLP-1s or not.
Yeah.
I think online it said, in general, weight loss is about a third of your muscle loss that you have. When you lose, let's say you lose 20 pounds on a quicker side, that a large percentage of that is muscle mass for people who do those like quick diets.
Yeah, I like to keep it below 10% of the total weight loss.
Okay.
And because also really something really interesting that people don't know, that I didn't know until I started seeing body composition after body composition, is that when you lose muscle, you don't lose as much percentage body fat, no matter the dose of the medication that you are. So we're fighting against your metabolism, because muscle is our metabolic organ, right? So if you're losing muscle, you're slowing down your metabolism. And in those patients, we need higher doses. It's very hard to bring them down because they're relying 100% on the drug, not muscle can help with the metabolism. So it really, how you preserve muscle is going to dictate how you lose percentage body fat.
Okay. So in that case, if someone is on that, how often should they be? Because then you probably want to be checking the body comp every certain amount of time, or is that how it works?
Yeah, I do a body composition every visit. So every 8 weeks,
okay. So you can really see
Yeah, I think earlier than that, it's hard to see any muscle gain, right? Especially for those that we're working towards muscle gain. I think it's enough time to get a good gauge of what's happening.
So at minimum, every 8 weeks, so every 2 months.
Yeah, at a minimum.
Okay. I had someone ask, when you do achieve your goal weight, is it okay to go cold turkey with GLP-1s?
No.
Oh,
Absolutely.
okay.
Because think about it. So I'm just going to give an example of a patient that lost 80 pounds. I'm just making this patient up, but that we need to use the max dose of the medication. Usually the drugs have about 5 doses. So let's say we had to go to the highest dose to achieve the goal in regards to fat loss. He's getting or she's getting a lot of suppression from the high dose of the drug, right? You cannot take somebody from 100 suppression to zero suppression. That's when they feel ravenous, right? They're going to feel the return of the hunger like something uncontrollable, and they'll regain the weight. See, that's what happens with restrictive diets. You stop at cold turkey, and then the restriction is out of the window. The ravenous hunger comes in. So as we went up on the dose, allowing you to adapt to higher dose, we need to come down gradually on the dose so you adapt to feeling a bit hungry little by little to a dose that will be used for maintenance, right? So that can take as much time as it took going up, then coming down on the medication.
So I would imagine this, again, is why you work with someone who's a specialist in this versus going to a med spa. Oh, that's very helpful to know. It's almost like with certain drugs, you can't just be on it and then drop cold turkey. It has to be, you have to wean off of. Oh, but so do you never wean off of it? Is it always just a very low dose?
It depends on the history of the patient, the individual history. I would say if patients have struggled with weight since childhood or puberty and they're in their 30s, 40s, 50s, then most likely they will require a low dose maintenance long term. If it's somebody who never struggled with weight and after pregnancy couldn't lose 30 pounds, then most likely that patient won't require long term medication.
Oh, okay. That's helpful to know. Are there any misconceptions about who should be using GLP-1s? Like what if someone is not significantly overweight, but they struggled, in their opinion, to lose their last 5-7 pounds?
And this is very common in women in midlife, right? I think I hear this more from women going through perimenopause and menopause, that they're doing everything that they can, that they're doing the same or even more than what they were doing in their premenopausal years, and they just keep gaining weight or they cannot lose the weight. So my rule of thumb is, if what you're doing in regards to lose those 10, and by the way, every time somebody comes and thinks that they need to lose 10 pounds, it most likely is like 20 pounds when we do a body composition, right?
Okay.
So in those patients, the question is, what else in your life can you do to achieve that weight loss, that it doesn't become extremely restrictive, because that will not be sustainable, right?
Yep.
And how much does it consume in regards to your mental health and your physical time, right? For some patients, to lose 10 pounds may become a full-time job and completely consumed by that, right? Why? Because it's not the nature in their body to lose those 10, 15 pounds. So those patients will benefit from medication. Maybe there will be a short-term use of the medication, right? This is like an example of somebody who will need it short-term. So it's what part of how much of your life can you invest even more without becoming extremely restrictive that would not be sustainable long-term. So it'll depend on that answer. And that's when.
Okay. Wait, so sometimes people do this as a short term. I mean, I just know how people are.
No,
they want to get ready for a wedding. They want to lose some weight.
That's not somebody who's doing everything they can in regards to exercise and eating healthy, right? That's somebody that wants something quick. No, I'm talking about the patient that is doing their homework. They know the nutrition. They're doing their weightlifting. They're doing their exercise. They're mindful. They're cutting back alcohol. They're doing everything possibly that they can in their hands, on their side, to try to lose weight, and it's not happening. I'm talking about those patients.
Okay. And then I wanted to just talk about weight loss in general, because a lot of the people who listen are in perimenopause or menopause. Can you talk about some of the other struggles that you I guess encounter with that population of clientele, midlife women in perimenopause or even postmenopause? Is it essentially those last 5-10 pounds, or what are some of the challenges they come to see you for?
Definitely, I don't think I've seen anybody with 5 pounds difficulty to lose.
Okay.
It's more like the 15, 10, anywhere from the 10 to 20 or even to 30 range, right? That they just start accumulating. I mean, many times with patients with perimenopause and menopause can have symptoms due to their menopausal state that will limit them from exercising to their full potential, right? So lack of sleep, night sweats, hot flashes. things that will decrease somebody's quality of life is going to impact their weight too. And we see this more commonly around this age.
Mm-hmm. This is what a listener had asked. Is it important to lose fat if you're eating properly and exercising? Like if all those kind of factors are in?
It depends, right? What's your percentage body fat? Because if your body fat is within a healthy range, well, no, you don't have to lose body fat. It's where's your visceral fat? What's your percentage body fat? If you're in a range that you're at risk for disease, then definitely that you need to bring down your body fat.
Okay. And then I actually had someone ask, and I know this is probably like the $1 million question. How do I lower my visceral fat in perimenopause?
Well, hormone replacement therapy can help with that because the drop of estrogen is what it can increase our visceral fat during perimenopause and menopause. So estrogen can revert some of your body composition, including visceral fat. Also visceral fat, diet, alcohol, sugar, that also can promote inflammation, insulin resistance, right? So basically anything that increases your resistance to insulin is going to increase visceral fat. Anything that decreases your insulin resistance is going to decrease your visceral fat. We're talking about simple sugar, simple carbohydrates, alcohol, inflammatory foods, basically.
Okay. Then I had someone who was in their early 40s asking, at what age should someone consider HRT? But let's say you're starting to see cycle changes in menstruation. You're noticing body composition changes, but maybe you don't have any terrible symptoms. So is it better to be proactive versus reactive in terms of HRT and perimenopause?
If we go by the current guidelines right now, it's more until the patient has more life-altering symptoms, right? The night sweats, the hot flashes, the trouble sleeping. We definitely want always priority is to make people sleep and to allow people to sleep. I think that's the basis of everything that we're talking in regards to health. I would say in a point where your symptoms don't start affecting your day-to-day, that would be a good point. We don't have to wait until you become fully symptomatic and you're miserable for us to start hormone replacement therapy. But if you're in your late 30s and you're not having symptoms, that's being too proactive, right? So we just have to find, it's an individual case, right? It's an individual assessment.
I think it's probably getting confusing for people because before it was just, no, HRT is not great for you. And now we're hearing all these, I guess, positive benefits. So someone asked, and you kind of answered it, but I'd love to hear you talk a little bit more. Will estrogen help with my body comp if I'm already lifting, I'm doing my long, steady cardio, and I'm managing my diet?
Yeah, definitely. I don't want to promote hormone replacement therapy as a weight loss treatment, right? Or life-changing body composition changes. I think it can help, but for some patients, they may benefit from GLP1’s, right?
So I know this is a little bit more divisive. Even my gynecologist had suggested, she goes, but it's not, I guess, recommended yet by the North American Menopause hormone pellets. So I know you've done a post on it. I was wondering if you could talk more about, for example, testosterone pellets.
So as an endocrinologist, what we do is whenever we replace a hormone, we want to mimic what your body does naturally, right? Your body produces testosterone every day. Your body produces estrogen every day. So whenever insulin, right, we give it every day, multiple times a day. So thyroid hormone, we give it daily because our gland will produce it daily. The problem with pellets is that it's not a natural replacement of the hormone, right? And we don't have, and we lose control once the pellet goes in. The absorption may vary from person to person. You may absorb a higher amount than more of a gradual release, right? So, and it's an invasive procedure to insert the pellets, and it's an invasive procedure to remove the pellets. So that's the reason that as an endocrinologist, we do not recommend pellets. We have options. We have other, if we didn't have any other option, then we will work around it. But we have options that are safer and FDA approved.
Okay. Oh, like the gel. I think I know on your post you use
The testosterone
a gel.
that will be a daily application.
And I was wondering if you can talk about your thoughts on hormone therapy even after menopause.
So hormone therapy has two purposes, right? One purpose is to resolve acute symptoms that the woman is having, right? Like the trouble sleeping, the hot flushes, and night sweats. Those are, I like to call them palpable symptoms that will improve with hormone replacement therapy. But the other benefit of hormone replacement therapy is preventative. Unfortunately, our indications for HRT at the moment are more to treat and not to prevent. But we know from all the data that it is preventative from cardiovascular disease, bone mass loss, muscle mass loss, cognition, dementia, right? So for those reasons, for the preventative reasons, then we could use it and we should use it long term. Before we used to have the 65-year-old was our top in regards to how long to give hormones. But really, we didn't have any basis on saying that, just saying that we didn't see any improvement in any symptoms at that moment anymore, because most likely the symptoms were gone away of menopause. But at the moment, it's more
right
as long as the patient wants to take them.
Okay, I like that answer. I know that it's not been there's not an official statement by the North American Menopause Society saying that you can take it for the rest of your life. I was just curious.
But I'm on. Dr. Marisa Haver says that she wants to be buried with her estrogen.
I remember I've seen that because I'm on it. I'm already postmenopause, and I'm on and it completely helps with my sleep.
I want to be buried with my testosterone gel.
I saw that you wrote that. Oh, and actually, that was going to be actually one question: is progesterone's primary benefit when you're taking hormone therapy just to protect the uterus? So if you don't have a uterus, do you need to do estrogen and progesterone?
So yes, the main function of progesterone, talking about replacement, is to protect your endometrium, the lining of your uterus, from developing endometrial cancer from the unopposed estrogen. So that's what our body does naturally, produces estrogen, and then the progesterone takes away the lining, which comes as a menstrual period, right? So it's cleaning itself every month. So this is the function of the progesterone. So if you don't have a uterus, if you had a hysterectomy, in theory, you don't need progesterone, and that's what we do for most patients. But some patients, even without a uterus, may benefit from the progesterone, specifically on the sleep. When the estrogen is not enough to improve the sleep, the progesterone can really come and help with the sleep. So there's no absolutes anymore, and this is another one.
That is very helpful, that there's no absolutes anymore. And then the last question is regarding what you just said. So I know you use testosterone gel, and you said you want to be buried with it. Can you share for the audience, I guess, why? What other benefits besides sex drive related using testosterone gel?
It's a sin to reduce the benefit of testosterone to sexual function. I will say that it has so many other functions that if we think about it, that we associate with testosterone, right? And that we may associate with a man is stamina, energy, focus, sharpness, just overall sense of well-being. For what it does in HRT, it comes in as like the missing link or the missing puzzle to really get all the benefits from HRT. For the majority of patients, when they are on testosterone, this is what they say: oh, this is what I was missing. This came and really completed everything. And I have to tell you that the benefits that the patients are the happiest about have not to do with sexual function, right? It's just how overall they feel.
Oh, that's fantastic. Well, those are, let me see, make sure someone had one question about, is it worth trying DHEA before testosterone?
There's not enough studies, and we don't have an FDA approved DHEA. What we have is more like a supplement, and with supplement, we don't know exactly what you're getting, right? Maybe
There's no
testosterone and
regulation.
DHEA. We
Yeah.
don't know. Who knows what you're getting?
Okay. Well, Dr. Salas, I am so grateful for your time because you're Instagram famous, and
And I see patients every day.
everyone can find.
And I see
What's that?
patients every day. That's my real job.
And I was wondering how you create all that
My real
content
job.
and actually see patients. Exactly. I'm going to put all the information about how to reach you, if someone wanted to set up an appointment in New York City with you in the show notes. And thank you all for listening. Thank you, Dr. Salas.
I'm Coach Tina. For more information about how to work with me, head to ironstrongfitness.com and send me a message. I'll see you next time.